Morning, everyone. So I'll be talking about irritable bowel syndrome in this class. Irritable bowel syndrome is a functional bowel disorder, and wherein you have recurrent abdominal pain, mainly associated with abnormal defecation in the absence of structural abnormality of the gut. So most commonly seen in young women, okay, and it is mainly associated with fibromyalgia, headache, and backache. Okay, and always it's remember it's a functional bowel disorder. There is no structural abnormality. It's always a functional bowel disorder. So diagnostic criteria, there's a criteria known as Rome 3 criteria. So wherein the recurrent abdominal pain or discomfort for at least 3 days per month in the last 3 months associated with either two or more of the following, that is improvement with defecation. The patients, they feel that the abdominal pain or discomfort is relieved with defecation, or onset associated with the change in the frequency of the stool. So initially patient may have diarrhea, and then patient may have symptoms of constipation, and onset associated with the change in the appearance of the stool. Okay, that is the appearance of the stool and frequency. So pathophysiology, you have GI motor abnormalities, colonic motor abnormalities, which are more prominent. Okay, colonic abnormalities are more prominent, and motility index and HAPS in IBD are mainly increased. IBS diarrhea predominant. In IBS you have diarrhea predominant and constipation predominant. In it is in diarrhea predominant, it is mainly increased. Visual hypersensitivity, the proposed which are mechanisms which are endogen sensitivity. You have silent nociceptors, CNS modulation mainly in the cortex and brainstem, long-term hyperalgesia, neuroplasticity, tonic cortical regulations. So CNS dysregulation, you have mid-cingulate cortex, which has greater activation, and prefrontal lobe increases the alertness, and it's mainly associated with emotional disorders and stress. All the patients of irritable bowel syndrome, they're mainly associated with emotional disorders and stress. Okay. Post-infectious IBS, it's more common in younger females, and it is triggered by acute GE-like illness, and it's increase in the firmicutes like bacteroids, and it is decrease in bifidobacterium and lactobacillus. Okay, and it is more common in the younger females. Abnormal serotonin pathways, the 5-HT containing enterochromaffin cells in the colon are mainly increased. Postprandial 5-HT levels are very high. Okay, so postprandial 5-HT levels are high, so that's why you have 5-HT blockers. So clinical features, patient mainly complains of abdominal discomfort. They may say abdominal pain, abdominal discomfort. It's not severe, it's only mild, and it is associated with disturbed defecation. You have constipation predominant, IBS with constipation predominant, or you have IBS with diarrhea predominant. Bloating is also more commonly seen in IBS. Coming to the spectrum of severity in IBS, um, you have prevalence, mild it's only 70%, it's 70%, moderate 25%, severe it's only 5%. So more commonly mild is seen. Correlations with the gut physiology, it's mainly positive and mild, less in moderate, and very less in severe. Symptoms which are constant in severe, more commonly seen. Psychosocial difficulties are more common in the severe type. Healthcare issues are also very commonly seen in severe type, and you have to refer in the severe cases. Risk factors, adverse life events, depression, so all these play a role. So the relative risk increases if there is depression, hypochondriasis, age greater than 60. Age greater than 60, it has negative, that is less than 1. So rarely seen in elder males, elder patients, more commonly seen in young. Female, you see, it's very high, risk is high, and smoking, the risk is very high. So smoking is one of the leading cause. So you have to ask to quit smoking as soon as possible. Lymphocytosis 3.2, enterochromafin hyperplasia 3.8, elongating toxin 12.8. Duration of the initial illness, it depends on the duration of initial illness as well. So in there is local inflammation, then leading to all the symptoms and the clinical features. Supporting diagnostic features and alarm features in IBS. The features supporting a diagnosis of IBS, the symptoms are greater than 6 months, frequent consultations for non-GI problems, previous medically unexplained symptoms, stress will worsen the symptoms. Okay. So alarm features, you have age greater than 50 years, male, um, and weight loss, and alarm in the sense, I mean, not commonly seen in these patients, but if it is present in that, then it's something you should think of something else. Okay. So maybe suspect CA carcinomas or inflammatory bowel disease. Those are commonly seen in all these. Weight loss is usually not seen in irritable bowel syndrome. So nocturnal symptoms are also usually not seen. Family history of colon cancer, anemia, rectal bleeding, all these are alarming features. Okay, these are not going in favor of IBS. New patient meeting the Rome 3 criteria for IBS. If the alarm features are present, then you have to evaluate for something else like CA colon and all. So do all the routine blood tests and stool tests, rule out celiac disease, and look for any structural colonic evaluation by doing a colonoscopy. And if the alarming features are negative, then you screen. First thing is you screen for celiac disease. If the celiac disease is negative, start straight away, diagnose as IBS and start the treatment. Failure of the therapy, you reconsider the diagnosis and testing. So which of the following below is the most important in managing patients diagnosed with irritable bowel syndrome? So extensive testing to rule out organic causes, reassurance to the patient that there is nothing wrong, advise food elimination, provide education and validation, refer to psychiatry. So testing is not very much necessary. Okay, you don't have to test much because there is no organic cause. It is a functional bowel disorder. Reassure the patient that there is nothing wrong. There is something wrong, but it's not major. So it's not that you completely fine. You have to reassure, no doubt, but that there is nothing wrong, that's not right. Advise food elimination up to a point, provide education validation, this looks very valid. You have to educate the patient regarding what is it and what kind of food you're supposed to take. So all that, so education is very important for that patient. Psychiatry is not necessary. 32-year-old woman is 4 months pregnant, presents with intermittent right lower quadrant crampy abdominal pain, gas and bloating. Stool is frequent and looks like pudding. Abdominal pain improves with defecation. So this is one of the important symptom of IBS. So, however, the stool is looser this time, and she also sees mucus. So mucus is not routinely seen in IBS patients. So you have to rule out any infection. Okay, which of the following tests would you recommend? Colonoscopy, no. Flexible sigmoidoscopy, no, not required. Endoscopy, diurnal aspirate or biopsy. I think stool study is the better test here. Just do it's a non-invasive test. Stool study for ova parasites and Clostridium difficile. Sequence of treatment. Uh, the patient has only bloating. You adjust the diet and treat constipation. The next step would be add a probiotic, which mainly contains Bifidobacterium, non-absorbable antibiotic, and add tricyclic antidepressant. So first step would be always to adjust the diet and treat constipation. And then for the predominant constipation patients, So any constipation patients, their predominant constipation, I always advise fiber diet. Okay, increase in the fiber diet, and give polyethylene glycol. Their next step would be lubiprostone or linaclotide. Okay, first step is always fiber supplement. Diarrhea, you can give loperamide, and then the second step would be 5-HT3 antagonist. I've already told 5-HT receptors are more prominent, so you have to inhibit. Allocetrone is the drug. Abdominal pain, the patient has severe abdominal pain, give him antispasmodic, and then give tricyclic antidepressants. So non-pharmacological, apart from the pharmacological, you have hypnotherapy. You may give up to 2 to 3. So no much adverse effects, and hypnotherapy works well. Cognitive behavior therapy can also be tried. Soluble fiber is very important. So low FODMAP diet. So FODMAP, you have to cut down the FODMAPs. FODMAPs is very important. Exercise is also very important in these patients, and probiotics. Okay, and probiotics also play a role. Fiber therapy in the setting of IBS is most effective in which of the following scenarios? Predominant abdominal pain and diarrhea symptoms, predominant abdominal pain and constipations symptoms, constipation only symptoms, diarrhea only predominantly abdominal pain, constipation and bloating symptoms. So abdominal pain, predominantly abdominal pain, the patient, you have to give antispasmodics. Yeah, definitely fiber is plays a role. Fiber plays a role in constipation symptoms. So answer would be constipation only symptoms. Okay, if the patient has predominantly abdominal pain, fiber therapy may not help a lot, because you have to give an antispasmodic as well. Pharmacological treatment for IBS constipation predominant. So you can give chloride channel activators, lubiprostone. This is the preferred drug. Guanylate cyclase agonist, linaclotide. All these are MCQs. SSRIs, selective serotonin uptake inhibitors. Then diarrhea predominant, you can go for rifaximin, 440 milligrams. You can give twice or thrice daily. 5-HT3 receptor antagonist, you have allocetrone, tricyclic antidepressants, and antispasmodics as well. Okay, the patient has predominant abdominal pain, go for antispasmodics. Peppermint oil can also be given for diarrhea predominant. 55-year-old business school professor mainly presents with daily symptoms of abdominal pain, daily symptoms, urgency and diarrhea. For the past 8 months, he has had several episodes of urgency while he was teaching, with near fecal leakage, and his anxiety of having an accident while lecturing has led to fear of teaching and a worsened cycle of symptoms. He had negative colonoscopy and mucosal biopsies. So there are no structural abnormalities. What therapy would you advise at this time? Okay, so it is diarrhea predominant. So it is always diarrhea predominant. Okay, so which is the better drug? The diarrhea predominant, always go for 5-HT3 antagonist, trial of non-triptyline 10 mg every night. This is the better drug here. Okay. Here 5-year history of postprandial abdominal associated with diarrhea and bloating. However, symptoms has worsened in the past 8 months. He has now has symptoms twice a week, and he denies smoking for symptom control. Okay, so he has abdominal pain, mainly abdominal pain associated with diarrhea. So because patient has this thing, trial of antagonist daily, trial of lubiprostone twice daily, trial of antispasmodic. This is better because he has severe abdominal pain, postprandial abdominal pain. This will work better. Antispasmodics will work better. So fruits, some common food source of FODMAPs. So these you should avoid. Okay. So FODMAPs, you have fruits, apple, cherry, mango, pear and watermelons. So these you should avoid. Vegetables, asparagus, artichokes, sugar nut, peas, grains and cereals, nuts and seeds. Milk products, more commonly seen. Milk products, yogurts, custards, soft cheeses, legumes, honey, high fructose corn syrups, food additives especially. So all these has to be avoided in patients with irritable bowel syndrome. So first, irritable bowel syndrome confer for reassure the patient. So you reassure him that it's okay. You have to. This is you educate him, and then the symptoms resolve. Okay, symptoms persist. You have to see if it is diarrhea predominant or constipation predominant. If it is diarrhea predominant, then go for avoid legumes. And first thing is you restrict the FODMAP, right? And if the symptoms persist, then go for antidiarrheal drugs like loperamide 2 to 8 milligrams daily, or codeine can give. And if the still symptoms persist, then they can go for amitriptyline 10 milligrams to 25 milligrams at night, or rifaximin can also be given. If this constipation predominant, first thing is fiber, add fiber diet. Okay, just increase the fiber diet. And if the symptoms persist, go for lactulose, can go for lactulose or isofagula. Then you can go for linaclotide or puclopride. And if the still symptoms persist, then you go for duloxetine, which is 30 to 60 milligrams at night, and then give relaxation therapy, and then hypnotherapy also can work. If the patient predominantly has pain abdomen, if the patient says yes, predominantly abdominal pain, then constipation or diarrhea. So first thing is you do dietary changes like low FODMAP diet, exclude wheat, dairy, and if the symptoms persist, then go for antispasmodics here. Okay, antispasmodics work better here. And probiotics also can be given. Rifaximin, if the patient has more of diarrhea predominant, add rifaximin or amitriptyline. Okay. And again, if the symptoms persist, again go for duloxetine. Duloxetine is the latest drug, and then give hypnotherapy. Hypnotherapy works well here. All right. Thank you.